This is Willie Kemp. This is Disorders of White Blood Cells Part 2. I'm sorry that on each of these short lectures I repeat various stuff, but I think it's very important for me to repeat my disclaimers on each one, my references, anything else, because I know some people are watching some of the lecture series, but not all of them, so I just want to make sure that each individual lecture is self-contained. So there's the websites I did with Dr. Hughes, where there's questions available, my Twitter, which I'll be a little more active on here shortly. And as I said, I'm a forensic pathologist by trade, but I have a very strong interest in general pathology, including organ pathology as well. And I have a really strong interest in teaching medical students. My disclaimers, please read these. If you do not agree, then do not watch the video. Third disclaimer, and if you're interested in knowing about my thought process on teaching and stuff like that, I got a lot of information from Make It Stick. Also, I've listened to people through the years and been guided by things and try to make the lectures as useful as I can, as interactive as I can, and then as best to help you retain the material as I can from what I've learned and what people have told me. Here are my references. Let's see. And then once again, thanks to the University of North Dakota's Department of Medical Laboratory Science. They have a fantastic hematopathology collection of blood smears, bone marrows. I was able to photograph them. Obviously, as a forensic pathologist, I don't really see the best heme path material. So I'm grateful for them for the opportunity to do that. So there'll be 2 questions. Once again, pause, look at it, see if you can come up with the answer. The idea is to help you pay attention during the lecture to fill in the question, and it is shown to help retention material from the lecture. Second question. Okay, so the first lecture was basically on non-neoplastic and a relative introduction to neoplastic. Now we're going to talk about specific non-Hodgkin's lymphomas. So we'll start with B-cell acute lymphoblastic leukemia lymphoma, or BALL. The stage differentiation and cell of origin, I put that there for all of them. It plays a role in the immunophenotype, and then I have a table at the very end in the last lecture that kind of lists all the translocations and lists all the immunophenotypes, so you can kind of see the progression. I would hope they would not ask you to be able to actually immunophenotype specifically some of these, because that's a lot of memorization. But at the same time, I can see them asking certain ones and expecting you to know certain lines, like knowing which ones are B cells and which ones are T cell markers. Or if there's a characteristic one for a certain type, knowing that one. And I'm trying to highlight that. So these are the most common childhood cancer. And it says usually in children under 15 years of age, peaks around 3 years of age, but it also occurs can also occur in adults. And then the T cell version occurs more in adolescent males, and it's more associated with thymus. Genetics in T cell ALLs, about 70% of them have a gain of function notch 1. In B ALLs, they have a loss of function of PAX5, and they have a translocation 1221 that involves ETV6 and RUX1. So I think that's an important one to know because it's actually associated with good prognosis. To me, I know that sometimes these seem like memorization, and they are, but at the same time, they're good test questions because they can ask you all specifically about what it is, and then the test question is supposed to have all the answers are supposed to be in the same category. So they're supposed to ask, whether mechanisms, complications, pathology, mutations associated with it, and that'd be a very easy one to give you the history with an ALL and then ask which of the following mutations associated with this. So the pathology of it, it's lymphocytic, so you'd expect to have really scant cytoplasm, fine chromatin because they're blasts, and we talked about the last time, that euchromatin, so it's kind of smooth throughout it. They're myeloperoxidase negative, which is going to help identify myeloids. And then in T cell ALL, they have a mediastinal mass, which is characteristic of that, and what you see in adolescent males. And then the cellular markers, I think one of the good ones to know is the TDT, because that's only expressed in pre-B and pre-T cells, and this is basically the main, if not the only one, that's in that category. Robbins has a lot of neoplasms, just, there's a lot more in a lot of the hematopathology textbooks and everything like that. You're learning some of the really basic ones. So there's probably something out there else that has it, but for your purposes, it's by far the main one. So, and then the difference between the B cell and T cell, and like I said, I have it all on a table at the very end on the last lecture too. So they used to lump this into ALL, L1, L2, and L3. It was dependent upon the amount of cytoplasm, I think, and the vacuolization. That I don't know if they currently are doing that, but these had been labeled as L1, L2. But you can see they're blasts. So they are the euchromatin is very smooth throughout the nucleus. The nucleus is very smooth. It's not smudged. So that consistent with a blast. Now, when you have the blast, it can be very difficult to tell, is it a lymphoblast? Is it a monoblast? Is it a myeloblast? And there's different staining that's used. So just based upon this, I would not want you to be able to expect to know that this is ALL. I wouldn't. I would be able to say, hey, these are blasts and some of the staining and stuff like that. So, okay. So some important points. They can vary in their maturity, as I talked about in the last one, and that can alter the immunophenotype somewhat. And I think there's like several different stages. Each one has a little bit difference. So very immature may be CD10 negative, whereas a late is CD10 positive. And what you'll see with the lymphomas is it seems like most of them are CD10 positive. So that's something that happens more with maturity. So understanding that would be good if you just know that, hey, CD10, and if you remember, it comes with all these mature lymphomas, it's more of a mature marker. If I don't see it, it's going to be more consistent probably with an immature cell. So things like that can be useful. Identifying some general patterns. So as I said, they're a very common tumor in childhood, but you can also see it in adults. And in childhood, children, you often see hyperdiploidy and that T1221 translocation, whereas in adults, they see the T922, which we'll talk about with CML, but it can also be seen in ALL. And then the T cell ALL, the P10 and CDKN2A are the genes mutated associated with it. So the way it presents, it's acute. So it usually presents with a relatively sudden onset. So it says days to weeks. And then what happens is the leukemic cells wipe out the hematopoietic cells. So they wipe out the normal hematopoietic cells. So you're not making red blood cells, you're not making white blood cells, you're not making platelets. So therefore, though they can present with anemia, they can present with thrombocytopenia, they can present with neutropenia and relative infections. The leukemic cells are growing inside the bone marrow, so it's going to expand it, which can cause bone pain. Obviously, as I said, there's crossover with leukemia and lymphoma, so you can get involved in the lymph nodes, lymphadenopathy, splenomegaly, hepatomegaly, and then it's also relatively characteristic, remember, to see testicular enlargement. The T cell ALL, since it involves the thymus, could potentially cause compression of the airway and large vessels, as it's in the mediastinum. And I think it's well known for going to the meninges too, and because of that, you can have kind of non-specific CNS changes. The headache, vomiting, but also potentially, since it's in the meninges, involvement of the cranial nerves, so some specific, where since they're kind of coming from the brain but passing through the meninges out, any inflammation in the meninges could affect them, and you could see that. I think these are useful to know, just the favorable or unfavorable. Favorable 2 to 10 years of age, less than 2 years of age or adolescence are unfavorable. Low white blood cell count is favorable. Unfavorable is a high white blood cell count. Favorable hyperdiploidy or the T1221 translocation. And then obviously if you have molecular detection of the residual disease after treatment, that's going to be unfavorable. So sometimes just if you just think about and not memorize, but really if asked, what would be more likely if they have a higher white blood cell count or a lower? Well, higher, they're producing more leukemic cells, that's probably going to be unfavorable. And then obviously if you can detect it afterwards, that's not favorable. So it's not absolute, but if you try and think through instead of just memorizing the list, I think it could be helpful. So this is actually Texas. I actually trained in Texas, and I currently spend some time in Texas. So I just like photographing the sunrise and sunset. When I was in Grand Forks for 5 years, it's very flat there. You can see to the horizon, north, south, east, west. And I really learned to appreciate the beauty of the sunrise and the sunset. Okay, so chronic lymphocytic leukemia or small lymphocytic lymphoma. So this is one that really crosses over. When it's mostly in the blood, it's more consistent with the chronic lymphocytic leukemia, but small lymphocytic lymphoma in the lymph nodes. And so they're both essentially the same disease, just more involvement in the blood, more involvement in the lymph nodes. So the stage differentiation is there. It's a naive B cell or memory B cell, so past the pre-B cell. It's mostly seen in adults, and it's about 30% of leukemia, so very common. So what happens in this is basically you promote BCL2. So you have mutations that allow for more BCL2 to produce. So BCL2, remember, is anti-apoptosis. So what this is, and this is a common recurring theme, is that these cells are actually immortal. They actually don't die because they BCL2 that's produced more of makes the cell so it doesn't undergo apoptosis. There's other ones that can be seen. Unlike most of the other lymphomas we talk about, SLL does not have, or CLL does not have a translocation. And then CLL are mature-looking lymphocytes. This one I showed you before with the heterochromatin, and they kind of describe the nucleus as kind of a cracked earth, like a dried cracked earth or a ginger snap appearance. And then SLL has relatively facing of the lymph nodes, kind of like mantle cell, but it has proliferation centers, which are mitotically active cells, which mantle cell does not. So the immunophenotype, it's a B cell, so CD20, and a really important one is CD5. So CLL, SLL, and mantle cell both are B cell neoplasms that have CD5, which is a T cell marker. So to me, that's a really good one to know because it really stands out. So chronic lymphocytic leukemia, and I'm putting up here some of the information just so it's repeated. So I think that CD5 is really important. But they're known for having the smudge cells, and to the right you can see that, where basically when it smears out, it breaks the cell, so it smudges it. And then that cracked earth or ginger snap appearance of the nucleus is all the heterochromatin, the mature, the chronic type cell. So some of the clinical features, it's often asymptomatic. I think sometimes the way this is picked up is on routine CBC for somebody going in for surgery or something like that, and they'll find they have an elevated white blood cell count. And they evaluate and they find out they have CLL. They could also present with fatigue and weight loss, and they can become hypogammaglobulinemic, so they can present potentially with infection. As with any type of leukemia, lymphoma, they can present with lymphadenopathy, potential hepato or splenomegaly. And then not only can they be hypogammaglobulinemic, but it is possible for them to produce autoantibodies, and they can develop a hemolytic anemia and or thrombocytopenia. And the prognosis is variable, and I thought this was a really good example of that. If they have a TP53 mutation, then they have a relatively small survival. But if they have 13q abnormalities, they have a near normal life expectancy. And this can be the utility of knowing some mutations. I mean, obviously, when you're in practice, you can look them up and stuff like that. But sometimes if you just know them off the top of your head and you're talking with your patients or things like that, it'll look better. So sometimes knowing the key ones can be important. So chronic lymphocytic leukemia, SLL, important points, I think. As I said, it can cause a hypogammaglobulinemia, and that's because it suppresses the function of normal B cells. But it can also induce normal B cells to produce autoantibodies, which could lead to a warm autoimmune hemolytic anemia. And one important thing about it is, so CLL and SLL are pretty indolent, but they can transform. And so what they can do is they can transform into a lymphoma-like, more aggressive neoplasm, which is called Richter's transformation. Okay, so first question. So pause, answer it, and then we'll go through it. So a 54-year-old man presents to clinic with complaints of fatigue and weight loss. Physical exam is remarkable for generalized lymphadenopathy and hepatosplenomegaly. Laboratory testing shows a leukocytosis. Subsequent lymph node biopsy shows small round lymphocytes effacing the normal nodal architecture. Flow cytometry shows a population of cells expressing CD5 and CD20. Which additional laboratory abnormality has most frequently been reported in association with the patient's likely diagnosis? This one's not the best wording, but this is describing a person with CLL, SLL, the CD5 positivity, and then they can get the hypogammaglobulinemia. And then there's the answer. So a 5-year-old boy is brought to, answer the question, and then we'll go through it. Pause. Okay, a 5-year-old boy is brought to clinic for evaluation of fever, fatigue, weight loss, and recurrent bruising. Laboratory evaluation shows a marked leukocytosis with decreased numbers of red blood cells and platelets. Peripheral blood smear shows numerous blasts. Which of the following immunohistochemical markers would have the most utility in the initial classifications of the child's illness as an acute lymphoblastic leukemia lymphoma? So answer, TDT. So it's talking about the features the child's seeing with the fatigue, weight loss, recurrent bruising will be from the thrombocytopenia. So it's basically from the leukemic blast wiping out the normal hematopoietic cells. And like I said, I just think that's a good one to know, because then you know they can present with that anemia, infections, bleeding, or some combination of those because of that. And then remember, with TDT showing that really early cell, that's the most useful one. The CD19 would be expected later on, potentially part of it, but we're thinking the TDT is the best one for ALL there. And there's the explanation they wrote. And so once again, just use reflection, stop the recording, look back and say, okay, what are 5 important points? And once again, I hope I've made 5 important points during this, and this really helps cement the material. Like I said, if you want to read a book on learning or on teaching, read that Make It Stick. It's fantastic. And then they talk about a medical student went from bottom of their class to top of their class using this one technique, and I use this quite a bit. So in North Dakota, I also learned the beauty of the sky, the cloud formation, everything like that. Growing up in Libby where there's a lot of mountains, it's a lot different when you're in a flat area, but I learned there's some beauty to the sky and stuff. So I hope this has been useful in your understanding of neoplastic disorders of white blood cells, and thank you.